Hi, welcome to our presentation on the well newborn. So our learning outcomes for this activity is to describe the newborn periods of reactivity and behavioral states, describe the expected physiological changes and common alterations observed in the newborn during the transition from fetal to neonatal life, identify the significant maternal fetal history that could influence patient outcomes, and design patient-centered care that supports the newborn in adapting to extrauterine life and contributes to positive patient outcomes. So when we look at after the baby is delivered, we're looking at periods of reactivity. And so there's some optimal times for parental bonding. The baby's typically very alert with mild tachycardia and tachypnea, lots of increased muscle tone and muscle activity right after birth. So that's the first period of reactivity lasts for about 30 minutes after birth, and then the baby's really kind of exhausted from his or her journey into the world. So we think we really want to optimize on this period of reactivity, and this is a great time for maternal newborn bonding, maternal father newborn bonding. And when we're looking at trying to initiate breastfeeding, taking advantage of this first period of reactivity to see if the baby will latch on or at least nuzzle the breast, because this is going to get all the hormone cascades going to help establish breastfeeding. The second period of reactivity occurs about 2 to 8 hours after birth, and it can last as short as 10 minutes and last as long as a few hours, where the baby is alert, looking around, basically trying to figure out what's going on. So let's look at the physiological adaptation. So surfactant is a phospholipid. It reduces surface tension. So what you want to think about is it keeps, if you read the bottle of like Dawn dishwashing liquid, not to favor a brand, but if you do, it'll say it's got surfactants in it. That's what kind of gives it that slippery, slickery kind of feel. And so you can imagine if you had a balloon that like you blow up for a kid's birthday party and put a couple of drops of dishwashing liquid in there, it would make it much easier to blow up the balloon. So it keeps those little alveoli from collapsing. So it keeps those alveoli open. And it's usually present by it's detectable about 21 weeks of gestation and increases in amount by about after week 24. Initiation of respirations results from an increase in PCO2 and a decrease in PO2. And there's a nice link here for you to look at that has some good information. So the characteristics of established respirations. Babies are the funniest breathers you can imagine. It isn't like they just breathe in and out like all the rest of us do. What they do is they kind of go quick, then slow down, pause, and then go again. So they have some interesting respiratory patterns, but they also can get something called transient tachypnea of the newborn. And basically there's some fluid that's left in the lungs, so the lungs are a little bit wet. How much respiratory distress, it varies on how much fluid is in their lungs, but we want to make sure that they don't have an underlying infection or any kind of pathology. that's causing it. It's more common with C-section babies. If you can imagine, the C-section babies, they don't get that squeeze down the birth canal that the vaginal delivery babies do. So that good squeeze, you know, is helps empty the lung of fluid. It can occur in term or preterm babies. As I said, it's more common with your C-section, and people with very fast labors, they don't get a good chance to really empty out. And on the x-ray, it will show some streaking with some fluid. So when we look at the physiological adaptation, we have to think back to the fetal circulation. So, you know, the fetus, it doesn't use its lungs. So it shunts blood away from the lungs and everything comes in through the umbilical cord. So the fetal shunts involve the ductus venosus, the ductus arteriosus, and the foramen ovale. So which side has higher blood, has higher pressure? At birth, the initial breath is going to shift that circulatory pressure. So we're going to remove the fluid and expansion of the alveoli decreases. There's a rising pressure on the left side of the heart, dilation of the pulmonary vessels and increasing oxygen levels, and that causes the blood to stop shunting away from the lungs. So now the blood has to go to the lungs. So typically with the first breath, the ductus arteriosus will close. So part of our nursing care is a full cardiorespiratory assessment. The baby's typically in a sinus arrhythmia, their pulse kind of speeds up, slows down. It's not unusual to hear a benign murmur. It's because they still have a little bit of the ductus arteriosus open. They do that periodic breathing, and we're going to hear some of that moisture in their lungs is exhibited by ralls and crackles. We want to monitor their vital signs. So this is their typical heart rate, 110 to 160, kind of like our fetal monitor strips. Respirations are 30 to 60, and the blood pressure is 60 to 80 over 40 to 50 millimeters of mercury. We want to look at their color. There's a difference between central cyanosis and acrocyanosis. Acrocyanosis is a little bit of a blue color to the hands and the feet, and that's just because most of the circulation comes to the vital organs, the brain, the heart, the liver, the kidneys. Those things need the circulation more than your fingers and toes do, so they'll get a little bit dusky. Central cyanosis is when we're getting cyanosis of the trunk, cyanosis of the gums, mucous membranes. That's showing that the baby is not oxygenating well. And here's just a nice picture, the little circumoral cyanosis, just a little cyanosis around the mouth, but you can see that the tongue is pink and the lips are pink, and down at the bottom we're seeing the little bluish tinge of the hands and feet. That's a little acrocyanosis. So a big job that the babies have to do is to learn how to keep themselves warm. They cannot shiver. They cannot shiver to make heat. You can shiver if you're cold. They cannot shiver. So what we want to do is we want to make sure that we put them in an environment where we can keep them warm and not make them burn their brown fat to release glucose for energy. And I'm going to show you a nice little diagram of brown fat on the next page. What you can see in this lower picture is a baby warmer, and if we put babies on a cold surface, they'll lose heat. So we want to put them on a warm surface. We want to make sure they're dry. So these are things that we can do. They lose heat through their heads, and that's why that little baby at the top has got their nice little hat on. Their hats are disproportionately larger than the rest of their body. So these are some nursing interventions to keep in mind. This is part of keeping them warm. So when we're looking at brown fat, it's unique in term newborns. Yeah, preterms have brown fat, but not as much. These little areas that are darkened show you where the brown fat deposits are. So you can see their interscapular region, axilla, along the vertebral column and around the kidneys. And what brown fat does is, if we're not keeping the baby in a neutral thermal environment, the baby will burn the brown fat. It's kind of like, having a little campfire to help them increase heat production, but this can also cause them to get hypoglycemic. There's different methods of losing heat. One is evaporation. It's like you getting out of the tub, you're sopping wet, you're running around your air-conditioned apartment or house, and you're going to get cold. You're losing heat through having that moisture because we're not dry. And so what we do is we want to make sure we dry well after birth. That's real important. Even when we're putting the baby on mom right after delivery, we want to make sure that, we dry the baby off, put the nice warm blanket over mom, over baby, but don't leave wet baby skin exposed to the air. So we always want to get rid of those wet blankets. Radiation is a loss of heat to cooler objects in the environment and not in direct contact. So we watch where we put our isolates in our open beds. We don't put it near an exterior wall because typically it's cooler outside and we'll lose heat by radiation. Conduction is a loss of heat through direct contact with a cooler object. That's why we warm our warmer up before delivery, and while we have our warmers all ready to receive new babies in the receiving nursery, is that we want to make sure that they're not going to lose heat through conduction. Convection is the flow of heat from placing it near a cooler ambient air, putting the baby near a draft, putting the baby near a fan, putting the baby under an air conditioning duct. And here are some pictures to show you the ways that the heat is lost. But the important takeaway message is, do not let babies get cold, because otherwise it will burn brown fat. If they burn brown fat, they can get hypoglycemic. If they get hypoglycemic, they can go into respiratory distress. If they go into respiratory distress, they can, they may have, they're in turn they're burning more blood glucose. They're going to get hypoglycemic. So things go round and round and round in little circles with babies. This is just a nice little illustration that what happens if we cold stress a baby. So you can see how it affects a bunch of things. So it's affecting oxygenation, it's affecting glucose levels just by getting them cold. So being cold can affect their respirations and affect their glucose metabolism. So what's an optimal temperature that we want to keep these babies in a really good environment? So we want to keep the optimal temperature in this range here, 97.7 to 99.5. So we want to keep a neutral thermal environment, placing an infant on a warm surface and using dry blankets. Dry the baby well at birth. Use caution during bathing. Cover the head. Remember, their head is disproportionately larger than the rest of their body, and dress in layers so we can kind of add things or decrease things um, as needed in the delivery room. And of course, we want to educate the parents about how to dress baby. So now we're going to look at the sweets. We've looked at the pink, we've looked at the warm, now we're looking at the sweet. So we want to maintain our blood glucose within normal limits, and it can be challenging for some babies. So what happens after the umbilical cord is clamped? Well, the baby's relying completely on themselves to seek out sources of nutrition. So that's why hopefully they've got a good suck, they'll latch well, their suck and swallow is coordinated, because now the source of nutrition is no longer available. They're not attached to mom, that's gone. So when we're looking at the plasma glucose levels, these are the values that we're looking at where we want to keep the babies, about 50 to 60 during the first few hours after birth, and then 60 to 80 milligrams per deciliter in the first week. Hypoglycemia is defined as any blood sugar less than or equal to 40 milligrams per deciliter. Some babies are more at risk for having low blood sugars, and those are infants of diabetic mothers, and we've gone over that in that module. Are large for gestational age babies, or small for gestational age babies, or low birth weight babies. Well, think about our SGAs and our low birth weights really don't even have that. They have less brown fat and less reserve. Babies with traumatic deliveries, we've used up a lot of resources just being born. Cold stress and asphyxia. Again, that warm, sweet, and pink little cycle go together. And here's a nice picture of a large for gestational age baby, who I like to call the Michelin Man baby. And so what we want to do for our babies who may be having difficulty swallowing, our best source of nutrition is get them onto mom, get them to latch. That colostrum is concentrated, it's high in calories, it's very good to regulate their blood sugar. So if the mom is willing to breastfeed, this is an awesome thing. Even small tiny babies that are preterm, low birth weight, maybe don't have a good suck and swallow, we can have mom hand express her colostrum, and then we can syringe feed the colostrum to babies to help keep their blood sugar up. So some signs that we're looking for, we want to monitor for signs and symptoms of hypoglycemia. The babies will be jittery, they'll be lethargic, they may have feeding problems, they just don't have the energy to feed. Feeding takes energy. They may have seizures. There's just some photo links for looking at jittery babies. There's typically a glucose protocol in each nursery about how often to do glucose sticks, and how much to feed, and the feeding and the parameters to report. And so which risk factors can be prevented for these babies. So hopefully our biggest thing is that we want to make sure that our diabetic moms are well controlled. That's one thing that we can hope that will reduce the risk of hypoglycemia, that moms get prenatal care, carry their babies to term, and that we're not cold stressing them or causing any respiratory distress that will make them go into hypoglycemia. So we talked about group B strep when we talked about infections, and along with E. coli, these are the leading causes of sepsis in term infants. So group B strep and E. coli. So realize that it's part of normal flora in women, and it lives in the intestines, migrates down to the rectum, the vagina, and urinary tract. We vaginally culture all women at 35 to 37 weeks gestation. If they're positive, we give them IV antibiotics in labor with a loading dose and then Q4 hours until delivery. And then what we do is we will treat the baby if they have risk factors of getting group B sepsis. So it's real important that we identify these moms ahead of time. If a mom who carries GBS is not treated with antibiotics at labor, the baby's at risk of being colonized with GBS, and that's about 50% risk. And then that increases their risk of developing a serious life-threatening GBS infection by 1 to 2%. On the other hand, if a woman with GBS is treated with antibiotics during labor, the risk of her infant developing early GBS infection drops by 80%. So for example, her risk could drop from 1% down to 0.2. And there's at least one large clinical trial right now in which researchers are studying the effects of probiotics on group B strep colonization in pregnant women. The study is scheduled to finish recruiting pregnant women at the end of last year, and so we haven't seen the results published as yet. So here's our GBS infection. Group B strep is very invasive. It can penetrate placental membranes, even if intact. The earliest symptom is respiratory distress, and since its emergence in the 70s, group B strep disease has been the leading bacterial infection associated with illness and death among newborns in the United States. It also has been attributed to stillbirths and preterm delivery. And microorganisms in the vagina can be transported into the uterus by digital exams and by uterine contractions. Perineal and vaginal ultrasounds offer an alternative to digital examination, especially before the onset of labor. In the infant's skin, respiratory tract, conjunctiva, gastrointestinal tract, and umbilicus may become colonized from the environment. So when we look at early onset of symptoms, it's a vertical transmission from the mother, resulting in pneumonia or sepsis, and late as 7 to 30 days later, colonized from the skin, and can result in meningitis or sepsis. And I've seen a baby that was probably a couple of weeks old that wasn't doing well, went to the pediatrician's office. Pediatrician realized something was awry, and by the time the baby got to the hospital, there wasn't much they could do for the baby. The baby passed. So risk factors for neonatal infections: if we have positive prenatal cultures on moms with preterm births, because typically it could be an infection that caused the preterm birth. Labor is an inflammatory process. Infections are an inflammatory process, and that's why we have to be so careful about moms and infections, because we don't want to predispose them into going to preterm labor. Premature rupture of membranes, that the membranes have ruptured greater than 18 hours prior to delivery. That's why when we think about when the membranes rupture, basically the clock has started ticking, because the baby's protection against those outside invaders is gone. If we see moms with a maternal fever of greater than 100.4 during labor, so what we want to do is we want to monitor for early signs of problems. Temperature instability. Yeah, you get a fever when you get sick. Guess what? Some babies that are septic, they can't maintain a normal temperature. So again, like sometimes babies who are septic have low white blood count versus high. Sometimes a very, very sick baby will have a low temperature versus a fever. They'll be lethargic or irritable. They may not feed well. They'll have vomiting and diarrhea. You'll see pale or mottled skin, and that this picture is mottled skin, and some respiratory issues. You may start to see respiratory distress, where with respiratory distress you'll see retractions, grunting. So it's real important that we try to protect our babies the best as possible. Number one tool is hand washing. So we really want to stress this to the families and to control visitors. And I always told parents is, hey, try to restrict the visitors, try to keep the visitors to a bay. If you don't want to sound like the bad guy, blame it on me and tell them that Miss Susan's the one that told you to restrict visitors. And that way you're still a good guy and I'm the bad guy and I don't even know these people. You always want to identify infants at risk for developing infection. Again, looking at mom's prenatal history, looking at the labor history. And we use erythromycin eye prophylaxis to protect the baby from developing conjunctivitis from either chlamydia or gonorrhea. Whooping cough, pertussis. So we're seeing now that there's things that we can do to try to protect babies. Babies, as I said, have very immature immune systems, and there is an increased rate of pertussis nationwide, and it's very, very concerning because it's a highly contagious respiratory disease caused by a bacteria transmitted through respiratory droplets, sneezing, coughing, talking. It's vaccine preventable, and it's very, very it can be deadly to infants too young to receive the immunization series or individuals who have not been vaccinated. Well, the incidence of pertussis has increased dramatically from about 1.8 cases per 100,000 persons in 1994 to 15.2 per 100,000 persons in 2012. And there's a significant increase in the incidence of adult pertussis that's been diagnosed in moms, family members, and infant caregivers. And so what we're trying to do now is we're doing something trying to call cocooning. Cocooning means anyone who's going to be coming in contact with the infant should have the adult vaccine, which is the tetanus, diphtheria, and attenuated pertussis, also called Tdap. And that children in the family have had their DTaP series. And when we get to the immunizations with kids, it'll make a whole lot more sense about what the difference between these vaccines are. But we really want to make sure that we're vaccinating parents, grandparents, people who work in daycares, make sure other family members, as I said, who are going to be around the baby to decrease the incidence of the babies getting infected with pertussis. So now, during pregnancy, we're actually giving the Tdap immunization to moms. In fact, my daughter-in-law just had a baby this summer, and she had her Tdap because her sister had given birth to preemie twins several years ago, and her sister was insistent that everybody that was going to come to the house had to have their immunization. And even though my daughter-in-law had her immunization, they still reboosted her during pregnancy. So you think that's too much? Nope, you can't over-immunize, but you sure as heck can under-immunize. Okay, let's kind of talk about their hematological system a little bit. Okay, going back to the fetal circulation. It's less efficient at oxygenation than the lungs are. So babies actually have higher hemoglobin and hematocrit. So they have more red blood cells to grab whatever oxygen will come across that placenta to bring it to all the cells in the developing body. So after birth, these red blood cells decline rapidly. Why? Because now they've got their lungs working, and those little fetal hemoglobin have a shorter lifespan than our nice mature hemoglobin. So how does the body dispose of all those old red blood cells? It conjugates it out through the liver, is what happens. So we can have the poor little liver can be bombarded by all kinds of blood cells that are being reabsorbed because the baby had some bruising during delivery or had a cephalohematoma, just the normal breakdown of the fetal blood cells. Or you can have pathological destruction, as in ABO incompatibility or RH incompatibility. So as you can see, we kind of go down the little garden path, And in our livers, we're always breaking and making new red blood cells, but our bodies are very efficient. It goes down to the liver. The liver packages up the byproducts of the broken red blood cell and sends it out through the urine and the stool. Well, babies, yeah, they can pack it up to a certain extent, but then they're not that efficient. So what happens is they wind up with it starting to deposit in the subcutaneous fat, causing jaundice. And if it gets too high in the bloodstream, it can cause staining of the of the brain tissue. That's called kernicterus. So unconjugated, which is your indirect bilirubin, can't be excreted and is toxic. So the liver conjugates it and makes it water soluble, called direct bilirubin, so it can be excreted. The unconjugated form is fat soluble and absorbed by the subcutaneous fat. And if you look at this YouTube video, if it plays, that's great. If it doesn't, look at Lucy and Ethel in the Candy Factory. Those of you who are I Love Lucy fans, I can give you a brief synopsis of what happens in this episode so you can kind of get the visual. Lucy and Ethel get hired at the Candy Factory. Their job is to take little chocolates that are coming down a conveyor belt, put them in a paper wrapper, and put them in a box. When the conveyor belt is slow, they're very good at their jobs. They pick up the chocolate, they wrap it, they put it in the box. That's what an efficient liver does. If you think about the chocolate as being the little broken red blood cell, the paper wrapper as being how we're conjugating it, and putting it in the box, we're excreting it. Well, when this conveyor belt gets sped up, all of a sudden there's all these little chocolates, also known as red blood cells, shooting down the conveyor belt. Some of them are getting packaged, conjugated, and put it in the little box, excreted, but some are not. And what's happening with Lucy and Ethel, they are sticking chocolates in their mouths, they're sticking chocolates in their hats, they're sticking chocolates down their shirts. So this is all the red blood cells, chocolates, backing up. So this is a really kind of good visual to really get in mind about what's happening, but in a more fun manner. So let's, again, we're looking at excessive red blood cells are being broken down by hemolysis. The liver's immature, and that's promoting hyperbilirubinemia, which is the accumulation of the bilirubin, which is the waste product of the broken red blood cell. So we see jaundice, which is a yellow pigment. It starts, when we first start seeing them jaundice, it usually starts in the face and works its way down. The further down the body it goes, the higher the level of jaundice. But is that an adequate predictor of gauging bilirubin? No, that's why we do bilirubin levels. And so one thing that'll also kind of make the bilirubin go up quick too is if the babies don't feed well, and babies have a sterile gut, and this also contributes to them becoming jaundice. So hyperbilirubinemia, the physiological jaundice, is that normal process breaking down those excessive red blood cells, and it's after 24 hours of life. It occurs almost in all newborns. It's more severe in preterm, in those with birth trauma, who got cold stress, poor feeding, and delayed stooling. It's generally benign. Unconjugated bilirubin typically peaks by day 3 at about 12 milligrams per deciliter and 15 milligrams per deciliter in preterm infants. The pathological jaundice, this is the part that when we see with the ABO incompatibility or the RH incompatibility, this is a review to you. The direct Coombs test detects clumping of the fetal red blood cells and maternal antibodies. And then we know that high bilirubin levels may cause kernicterus, which is a deposit of the bilirubin into the brain. So we can house that can result in permanent neurological damage. Now, a little aside too, in most breastfed babies, jaundice occurs in about 20 to 30% of them, and it's a little bit of a different mechanism than other jaundice, but it's not a reason to stop breastfeeding. We want the moms to be producing. The more they breastfeed, the more babies will poop. breast milk is a laxative and kind of gets that stooling going, because think back what I just said, delayed stooling can cause increased jaundice. So we really want these kids pooping to get rid of the bilirubin. So it's all linked together. The RH, out of the two between RH and ABO, RH is more severe, and the ABO occurs if the mom is an O because she's got antibodies against A and B, and the baby is A, B, or AB. So that's basically a little review of what I just said. And again, that is just a little bit of a review of stuff you had in previous modules, tying things together. And occasionally we have to give the baby an exchange transfusion because there's so much hemolysis the babies become severely anemic. So what we do is that we'll draw blood and check the baby's bilirubin levels. There's also little bilirubin meters that are used, but you'll see that we have to interpret the bilirubin level with age in hours. And this just shows you the zones of where the babies are at risk or not at risk based on the level. If they are at high risk, then they need to go under phototherapy. So how we manage it, is jaundice harmful? Well, we've established that jaundice can be harmful, especially if it starts depositing into the brain. It can cause neurological deficits. So we treat it with phototherapy. Hopefully some of you got to see it when you were doing clinical. Saw some babies under phototherapy. It's a fluorescent light, and it alters the bilirubin to a soluble form called So this is just a little bit of a summary of what I just said. So we draw that bilirubin at 24 to 36 hours for every baby. The challenges with dark-skinned babies, a yellow tinge of the white of his eyes or in the palms of his hands or soles or feet may be the only cue that we have that the baby is getting jaundice. There is a Billy tool designed to help clinicians assess the risks for the development of hyperbilirubinemia or jaundice in newborns over 35 weeks gestation. And again, the required values include the age of the child in hours and the total bilirubin level. Is sunlight adequate? Well, keeping babies out of the sun umbilical cord clamping. There's some different schools of thought. Traditionally, the cord was clamped within 1 minute. Then there's a school of thought about delaying the clamping until till at least 1 minute of age or once the pulsation stops. The looking at GI and GU adaptation, the term infant, usually has a pretty coordinated suck, swallow, and breath because babies can breathe while they're sucking, where we adults can't. It's just because our airways and esophagus, everything's on a bit of a different angle. So it's real important that we look for feeding cues and readiness to eat. And those feeding cues are making sucking sounds. If you stroke their side of their mouth, you'll get that Moro reflex stimulated. So those are signs of readiness to eat. Also, now the babies are ready to pass that first stool. Now, they usually pass it within that first 24 hours, and that meconium is thick. It's tar-like. It kind of freaks the parents out at first because they're thinking, oh my gosh, what is this? Because it really looks like tar. They think maybe there's blood or such in it, but it's just that stool they've been storing up for over the months in utero. Typically, we see them void. The first void within the first 24 hours, and it may be straw colored, may be cloudy due to mucus, and you'll see sometimes in the diaper, it's kind of like you see in this picture, it kind of looks like calamine lotion, which is like a pink lotion or Pepto-Bismol. That's what it looks like. So it's rusty colored uric acid crystals, just because that their urine, it's just little acid crystals that occur in the first few days of life, and then it goes away. There also may be a small amount of blood or mucus that are present with the female infants, and that's due to maternal hormone withdrawal, also called pseudomenstruation. So it's real important that we monitor newborn intake and output. And, we want to know. So why are diaper counts needed? Well, we have to know what goes in, comes out. Are they voiding? Are they stooling? And that's going to be a sign that they're adequately hydrated and eating enough. Infants should be feeding well and stooling and voiding prior to discharge. Parent teaching is really important, and typically the babies will lose about 7 to 10% of their birth weight, which they will regain by 2 weeks of age. The newborn screen is done. It checks for metabolic, hematologic, and genetic disorders. TEXA screens for about 29 disorders. The most common screening conditions are phenylketonuria, and you learned about that at your pregestational risks, congenital hypothyroidism, galactosemia, hemoglobinopathies, and congenital adrenal hyperplasia. So those are the most common ones that are detected. It's really important because, like with galactosemia or with phenylketonuria, if you're missing enzymes to digest certain kinds of food, then we need to modify that diet immediately, because if we don't, those bad metabolites will build up and can cause central nervous system damage. So babies that have certain enzyme deficiencies, we call them inborn errors of metabolism, they need to be identified early and to get put on special formulas. We can also detect cystic fibrosis. Now, in the newborn screens, sometimes babies with cystic fibrosis wouldn't get APGAR scores. It allows for rapid assessment of the newborn to determine the need for resuscitation. We evaluated at 1 and 5 minutes for heart rate, respiratory rate, muscle tone, reflex irritability, and color. So you get 0, 1, or 2 points for each category. If you score less than 7 at 5 minutes, the score is repeated at 10 minutes. A 5-minute correlates with the degree of risk for infant morbidity and mortality. So this is usually done by the nurse, though sometimes doctors have their back to you and then they're calling out what the APGAR is, but really the person who's got the stethoscope in their hand and the baby in front of them should be the person assigning the APGAR. This is how this gives us the parameters. So you can see how the 0, 1, and 2 are assigned. This is important to know how to do an APGAR score. Again, this is important to know how to do an APGAR score. So you can see 0 for an absent heart rate, 1 for slow, which is under 100 minutes, 100 beats per minute, and then 2 is for any heart rate over 100. Respiratory rate, if they're not breathing, they get a 0. If it's very slow, that weak, not a lusty cry, they get a 1, and they have a good lusty cry, they get a 2. Muscle tone, flaccid, no muscle tone, is a 0. Some flexion, not great, is a 1. Well flexed is a 2. The reflex irritability. So how do we do this? Typically it's by putting a little suction in their nose or flicking their feet. If they don't do anything, they get a 0. If they just kind of make a face, little grimy face, they get a 1. And if it really makes them angry, they get a 2. Their color, if they're blue, pale, they get a 0. If their body is pink and their extremities are blue, they get a 1. And this is where most babies will lose a point because a lot of babies have acrocyanosis. If they're completely pink, they get a 2. And this is just another scale that says the same thing, but going backwards instead of frontwards. And you can see APGAR stands for activity, pulse, grimace, appearance, and respirations. And it's named for Dr. Virginia APGAR, who was an anesthesiologist. And so her name just turned into the little acronym to help us remember what the parameters are. It's also important for us to know what the gestational age of the baby is, and this is just a Ballard score that we use, and it looks at physical characteristics, physical maturity, looking at different parameters, and as well as looking that's just a little link about the Ballard score. And this again just shows how we look at the weight and we look at what's considered SGA, AGA, or LGA. Bonding and attachment are really important, and we've talked about a little bit of this in postpartum. And so bonding is, we really want to have that strong emotional tie of the parent to the newborn, and that's a one-way tie. Attachment is the baby interacting back, and so that is a two-way tie. So it can be influenced by a lot of different things. Time, maturity, parental maturity and the condition of the infant. A baby who's really, really compromised, had a really rough delivery, may not be all that cuddly and bonding at first. So a lot of different things can influence how well this attachment occurs. So babies have 6 behavioral states: that quiet sleep state, where they're just resting quietly. They have an active sleep state when they're actually having REM sleep. And I've always been curious. I was watching my grandson this summer, looking at him, and boy, he was having some good dreams. A lot of times his little mouth was going, so I'm sure he was dreaming about eating. But so that's their REM sleep. And they have a drowsy sleep where they kind of look like somebody who really wants to stay up for the party, but really can't quite pull it off. And they also have a quiet alert state, and this is the ideal time to really get the baby and the parents to bond. They're quiet, they're not screaming their heads off, they're really checking things out, they're looking around, they really love faces. You make face, you smile, and they're really just checking you out. Then they have their active alert state where they're wiggling around a little bit more. It's not just, sitting there. They're a little bit more squirmy. Then they have that crying state where all 4 extremities are going and they are just howling with a lusty cry. So some positive indicators of bonding is the parents are willing to hold the infant. They call the infant by name, not it. When the baby's fussy, they go and respond to the baby. They're speaking positively about the infant. And factors that can delay this attachment is a traumatic or difficult pregnancy or birth. The mom is mentally ill. The mom abuses substances. Or you have an infant with a birth defect, because in mom's mind, she's got the perfect infant in her mind. The baby's going to have curly hair and a big smile, and the baby's born, and the baby's bald and has a cleft lip or palate. Well, this is not what she pictured, and so she's having a hard time accepting this baby. So what are some potential risks for every newborn? Babies are at risk for obstructed airway, inadequate circulation, transient tachypnea of the newborn, hypoglycemia, infection, hyperbilirubinemia, poor thermoregulation, and poor attachment. When we look at babies, another new thing that we started screening for in the nursery before discharge is looking for the presence of congenital heart disease. It's the leading cause of death in the U.S. of babies under 1 year of age. Early detection and timely intervention can significantly reduce newborn morbidity and mortality. And in Texas, it was nurses that really led the way, saying we really need to screen babies for congenital heart disease using pulse oximetry. And there's a nice little YouTube link here. And it's becoming more universal. I know my grandson had it while he was in the hospital. So here's a little screening algorithm. They place the pulse ox on the right hand and foot after 24 hours of age, and this shows you what the pass criteria is, what the and the fail criteria. So if it's indeterminate, they repeat the screen. If it's still indeterminate, they repeat the screen, and then if it's positive, it's a fail. So this just kind of gives you a little overview of the algorithm that's used. So this is just a little study about universal nurse home visiting programs after birth. There's always lots of research done, and this again shows how nurses are in the forefront of in maternal child health. They found that when moms are visited by nurses in the postpartum period, it really helps reduce total infant emergency room visits and hospital overnight. So the nurses are going out, they're checking the babies to make sure that the bonding's going well, the feeding's going well, do they have any questions? So they're looking at all at all of these different parameters, and they're really saying, okay, we need to get them back into their pediatrician, or things are going well. So these families that were in this study were given access to 3 to 7 nurse visits between 3 and 12 weeks of age. And nurses linked the families up with community resources as well. So again, nurses are in the forefront. So takeaway points. Good assessment of babies. Assess your babies from head to toe, right? Because they're going to develop from head to toe. So we're going to look at them from head to toe. Be aware of what the abnormal findings are, and you'll go a little bit more into that with your newborn at risk lecture. And you guys have got it. And so you're ready for ATI. Thank you for your attention.